Okay, so this is part two, and let's get going. I'm not going to spend too much time with the intro. We'll just keep going. So we're in this now. We're to pain control. Look, if there's any modality or any kind of intervention that is better at stimulating the sensory nerves and giving them a whole bunch of sensory stimulation to deal with, and then causing that substantia gelatinosa to click off and close the gate and just flood our spinal column and our brain with all these these electrical impulses. Man, it is Estim. So this is right up the alley. It does a very good job of gate control. There is an accommodation standpoint, so you may from time to time hear patients go in the middle of a treatment, hey, can you turn this up? And so that does happen. And then once you remove it, yes, I even mentioned that last time in class. Once you remove it, yes, the pain kind of creeps back, just like any gate control. Once you remove that A beta, A alpha stimulation, then A delta and C fibers, they're still there, and that comes back. As you look at the protocols, when we talk about pulses per second, we're getting into the higher pulses per second. So in general, right now, I can say lower is more muscle contraction-y, higher is more pain control. All right, so we can or gate control type stuff. The longer phase durations means if we apply it each phase, if we lengthen out the phase, we don't have to increase it as much to get a sensory feeling. So we're avoiding, that's just another way to avoid those pesky pain receptors and nerves. Shh, don't tell them we're here. And this is always a continuous current. We never really, go on and off for that. This is where, in the book talks about it as you read chapter 12, look at some of those, the noxious or opioid releasing type E-stims. That's where inducing some pain, right? When we talked about our pain control theories, the central biasing beta door, getting that enkephalin interneuron that comes from the brain down. It's a descending theory. So the way we do that is we have to get the pain up there to the brain to stimulate that. And it has to be a decent amount of pain. So there are some theories about, can E-stim treatments release endogenous opioids that are already in the body? I know that was redundant because that's what endogenous means, but sorry. So I don't put a lot of stock into this. I've never really done this. You'll see it from time to time. I think you need to know it is a use, or it's listed as a clinical goal. Some people may use it. You'll see that. The placebo effect is real because people get addicted to this. They like that feeling. It's also hard to do research on E-stim because it's hard to have a control group because they know they're not getting it, right? They know the tingling's not happening. And so if you just put pads on them and don't turn it up, you're like, well, there's nothing happening. So anyway, it's the placebo is kind of a unique little issue. All right, so we have, now I'm going non-excitable. So the two I just talked about, muscles and nerves, that's in the category of excitable tissues. With the parameters that we use, we can directly affect the function of the nerves and muscles. Now we go non-excitable tissues. This is where you start to kind of get into this like gray area. Like you really got to believe some of these things. I'll tell you a story about a salamander when we get into class, but ultimately it's from a healing standpoint. A lot of this stuff comes from a healing standpoint, and we're using the electrical current to alter or restore electrical gradients that get disrupted after injury. And so if that's the case, the theory sounds pretty good. Whether that actually happens, it's hard to actually quantify what's going on. I'm going to put some theories up there. You can read this in the book, but ultimately, when you look at this side, it's a lot of healing. So if the E-stim can actually do this, then we get a lot of generation or stimulation of healing processes, right? And same thing here. Even if we get gap junctions to start, gap junction. I don't know if you even remember that from anatomy physiology, but if we can get cells communicating in between and all that kind of stuff, is occurring, like I said, restoring those gradients that maybe become disrupted after injuries. There's a lot of things. Here's the big key. Here's the big takeaway. I'm going to put my face up here because this is important. When you talk about the non-excitable stuff, Most of these are going to be as a result of a monophasic, right? So if we're going to change the electrical gradients, right? If I want to make, if I want to push a bunch of negative electron or negative ions away from a certain area, I got to have a monophasic. I got to have a direct current that's going over and over and over. I can't have an alternating current where I push and then suck and then push. So if I get an electrical pole here, it pushes negative pole here, it pushes all the negative ions away. But then if this becomes the positive pole, and we pull them back. So we want to continue that. So it's usually a monophasic or a direct current of some sort. So that's important. I wanted to, because that'll come up in the next one as we go. So let me get my face back out of here. Goodbye. And as we go to the next one, edema control. So you have this is the real truth here. The real situation is that when I say let's put a stim treatment on to reduce edema, you have a choice. You can do that via muscle contraction, where you can see that, and muscle milking and pumping and all that kind of stuff to open up the lymphatic drainage. Or you could do this non-excitable stuff, right? You could just go, all right, I'm not going to muscle contract, and you can see what I just described is we're using the different ions to drive these negatively charged particles into the lymphatic drainage. And so look, if I have lymphatic drainage, have all this lymph fluid here, if this is and I put this, I just added this little negative ion. If all this stuff right here, if all this fluid has this overwhelmingly negative charge, and we come in here with a negative polarity, right? And we go, okay, let's turn it on. This now becomes a negative pole. Ions are flowing here from the negative to the positive pole. That's going to drive away it's going to push all these, hopefully, into the lymphatic drainage. That's kind of the theory there. Sometimes it's a big jump because you can't see what's going on, but maybe it works. And we can look at research. Maybe your article abstracts will pull something away. But ultimately, if you're going to set this up, and I think this, knowing the protocols to this is a good thing. So I already talked about it, a uninterrupted or continuous direct current, either from negative to positive or positive to negative, right? So you have a monophasic pattern going on. The frequency is going to be high. We're not doing muscle contractions. And then as you can see, look here, I'll tell you why the negative electrode is more distal when we get into class, because that has to deal with the salamander. So remind me if I don't talk about salamanders. But since we're trying to do this passively, the more treatments you can do and the longer treatments you can do to maximize this time is helpful. All right, our final one that I'm going to talk about in this video is the interferential currents. 279 in your text is where that is important. You'll see, I want you to read that. There's like a little box, and then there's some of the treatment protocols. That's in that last chapter of the actual how do you set this thing up. You have the bullet points here. So interferential currents, we're using two different channels, right? So that's why we have to have 4 pads. We got one channel on 2 pads, another channel on 2 pads, and you can see there's 2 different sine waves, that little curvy wave, and they're different, right? They're just a little bit different. And so that's what happens when we start to interact, when we start to add 2 different currents together. You get this interference between the currents. You have to know, I'm going to want you to know the difference between constructive, destructive, and continuous interference. So when you look at, if we have these 2 separate currents, so I have 2 pads right here, this is my current. 2 pads right here, this is my current. You can see that these are perfectly in phase. So they both are going up to the positive pole at the same time. It hits the peak and then down. So they're perfectly in phase. And so what you result in is a larger amplitude kind of current. All right, that's cool. Constructive interference. If we're exactly opposite, they basically cancel each other out and you don't get anything, right? So when we talk about interferential current, we're talking about continuous interference, where they're just slightly out of phase, just barely out of phase. If you look at these diagrams, these are the same diagrams in your text, they're just better colors. When I'm at the peak of this one, I'm not quite at the peak of that one. So basically you get a combination of constructive, destructive, but the main outcome is that you get this wave that goes up and down. So it's like up and it rises and falls in its amplitude. And that is what we're going to term, I just made this term up, the heterodyne effect. If I ask you what the heck the heterodyne effect is, number one, you're going to tell me it's it's two currents combining that are slightly out of phase, and it's a combination of constructive interference, destructive interference, and the result is a wave that rises and decreases in amplitude. Whew, that's it. That's easy. See how easy that is? Piece of brownies. Piece of cake. I know. Is cake better than brownies? I think so. You'll also see this term called the beat frequency, and that's really designed to confuse you even more than you already are. Ultimately, it shouldn't be that confusing. We're going to set the machine at a certain range, and so if you set it at 90 to 100 pulses per second, it's just the difference between those, right? The standard setting on our machine is 80 to 150, so the beat frequency is 70, right? So you just do a little math, little subtraction. This is the one that we're going to do a quad polar arrangement. We're going to have, in fact, let me get this. I can't get this out of it. Too far. I wanted this to be out of there, but you can still see channel 2. So if you focus on this one right here, basically you got channel 1. This is one current that goes from here to here. The other current, now we're crossing the streams like they told you not to do in Ghostbusters, but we're targeting the treatment area. So we put this little X pattern around where the area that we want to treat, and then in this area right here is where you get that interference or that heterodyne effect, that continuous interference. This picture down here just kind of gives you some examples of what that might look like. And so ultimately you're crossing, you have one channel, the channel 1 comes here, you have a red and a white here, a red and black here, and so you basically, here's your treatment area as you cross these two. You'll see this picture quite a bit. I think this picture is also in your book, and basically you have these areas of interference, and I don't know if this picture really helps me more than this picture, because ultimately it's the same thing to me. It's just, this is that area that you start to get this constructive interference where it goes up and down, up and down. Whether how it comes out at 45-degree angles, I don't know if that's even, you need to know that just as a BOC type question, but from a clinical standpoint, that doesn't really, ultimately what you want to do is you want them to feel the current in the middle. We don't really necessarily want to feel it directly underneath. We want it to feel it in the area that we're targeting. So we don't want to feel it underneath each individual electrode. We want to feel it in that treatment area that we're targeting, that we're sending those two currents to intersect in. Some of the machines have like a little locator that you can kind of angle it. That's kind of gimmicky to me, but yeah. So there we go. All right, you already saw my final one. I do have a couple of directions for you here coming up in the next couple slides as we go. But we made it through basically this is all the content in Estim. Now we just got to figure it out. Now we just got to kind of wrap our heads around it, remember it, do some of those kind of stuff. In your text, right now we go on to that third chapter a little bit. I do want you to read and just have an idea of what some of these different types of Estim are. You'll hear high volt pulse stimulation, HVPS, you'll see that. Transcutaneous TINS, you'll see that. NMES, neuromuscular electrical stimulation, that's kind of the machine that we have. So I want you to kind of get an idea of how those are different. Here's the deal though. In fact, I'll put my picture back in here. Look, here's the deal. All of these things they can all do the same thing. Right, and so some may be a little bit better for one than the other, but you can get muscle contractions with all these. You can get pain control with all these. So the actual what you pick or what you have is not a big deal. I say that because I want you to have an idea of of the different types that are out there that I'm just looking at my next slide. I probably should have changed this. but it's too late. I'm already 14 minutes in, 15 minutes in. So I'm sorry if this next picture offends you, if it's in bad taste. But if it is, then just focus on. I thought this was funny, but anyway. The focus on this. I want you to read these interferential currents. That's what we just talked about. Definitely Russian currents. We have that on there. We have both these microcurrent and Russian currents on there. And then I do strongly suggest, I'm not going to make you do it. No, not going to make you do it. But I strongly suggest looking at the Section 4 quiz. If there's some questions on iontophoresis, just kind of ignore those. We'll go over those, as a different section unit, but try to do those because it's important. All right, I'll get some. We'll have some fun pictures. I thought this was kind of fun. I don't know if anybody actually did this, but that's pretty hardcore. And then I think these are some photoshopped. I'm really hoping these are some photoshopped. That looks photoshopped. This one is a good job of photoshopping if they're actually doing it, as is this one. All right, 16 minutes, not too bad.